Um, Hello, everyone. This is Robert Fishberg. I'm with the Atlantic Medical Group at New Jersey with Overlook and Morristown. And I'm with the lecturer is Benjamin Hirsh, who's the Director of Preventive Cardiology at the Sandra Bass Heart Hospital at Northwell. And it's our pleasure to discuss how low is too low for LDL cholesterol. I just want to mention that this is a Opus Medicus designated course for 1 AMA credits, ABIM, and it's accredited by the Accreditation Council for Continuing Medical Education. And at the end of the course, you'll see an area where you could enter, you could get CME. And I believe you could enter your questions along the way in question answer. Don't do the chats. I do want to talk, this is a very important talk about how low your LDL cholesterol should go. We're not going to be discussing too much today about lipoprotein A, which is a whole different topic. Right now, there's no medications approved to lower LPA, but there are things in the future. And I do want to mention that at Atlantic, we're proud that I'm the director of called the All-Top program, which is a nurse practitioner-based program to lower LDL using a team approach. But again, I'm going to let Dr. Hirsh talk about this lecture today on how low is too low for LDL cholesterol. So Dr. Hirsh, take it away.
Thank you, Robert, and thanks to Opus Medicus for supporting this lecture and colleagues. We have an exciting talk for you tonight to discuss a topic that it really is something that we will commonly come across for many of your patients who are on pretty aggressive LDL lowering therapies. And it's a common question amongst patients and even physicians about how low is too low for lowering LDL cholesterol. Before we get started, just some relevant disclosures of mine, both from advisory boards, consulting, and funding that my institution receives, as well as Dr. Fishberg for speaking and numerous clinical research investigative support that he receives as well. With regard to the objectives of the talk, they're to review the evidence, the concerns, and also the lessons that learned when we treat to these very low levels of LDL cholesterol, to recognize that what's driving the formation of new guidelines and expert consensus decision pathways are the specific subcategories of ASCVD risk that are being defined that then drive the formation of these guidelines, and to understand how risk is being applied to guideline formation, and then to apply these guidelines and decision pathways to some clinical cases. So we'll start off with a case, and you can use a multiple choice button to choose your answer. So the 59-year-old woman, history of being a former smoker, hypertension, PAD, and coronary artery disease, previously had a PCI. The patient is on rosuvastatin 40 and evolocumab 140. Normal BMI, blood pressure is relatively normal heart rate and vitals. The total cholesterol is 77, HDL 37, LDL of 3, triglycerides of 100. Her A1C is slightly pre-diabetic at 5.8, and AST and ALT within normal range of the creatinine's 1. So in addition to recommending lifestyle changes, which of the following lipid lowering recommendations should you suggest on the basis of recent clinical trial data? would you reduce the rosuvastatin to 20, switch evolocumab to alirocumab, switch evolocumab to ezetimibe, discontinue the evolocumab and then recheck the LDL cholesterol, or not provide any further recommendations? So I'll give you guys a few minutes or a minute to input your answer. Okay, so so we'll go ahead and okay, so so that's the distribution. We'll circle back to the answers at the end of the lecture and see if this changes or not. Um, okay, going to the next case. 66-year-old gentleman, hypertension, hyperlipidemia, smoking. A smoker has is coronary artery disease, had an MI with PCI within the last year in October, on rosuvastatin 40, BMI of 48, blood pressure slightly hypertensive, and otherwise normal vitals, total cholesterol 230, HDL of 37, LDL 69, triglycerides 120, A1C of 6.1, and then ALT and AST elevated, just slightly above 2 times upper limits of normal at 100 and 107. So in addition to recommending lifestyle changes, which the following lipid lowering recommendations should you suggest based on the new LDL thresholds from the 2022 ACC/AHA expert consensus decision pathway? Would you add bempedoic acid? Would you switch to atorvastatin? Would you reduce atorvastatin to 10 milligrams, given the transaminitis? Would you add alirocumab, or no further recommendations? And again, I'll give you guys a minute or so to to respond. Okay, so so the majority of you said add alirocumab, but there's definitely quite a distribution here, so that should be pretty interesting when we circle back at the end of the talk. Very good. Okay, so we are now at a time where we're having numerous uh, options for lowering LDL levels to levels we've never seen before, outside of certain genetic mutations. With the 4A trial with evolocumab and the Odyssey trial with alirocumab, these are the two graphs showing median LDL levels in the 30s and the 40s for evolocumab, alirocumab, respectively during the trial. We are seeing LDLs to levels really we haven't seen before in clinical trials, and we're taking this concept and with PCSK9 in particular, and we're going even further with it. We're looking at not just blocking antibodies, but also blocking the production of the PCSK9 protein, which we're doing currently with inclisiran, and that's an every 6-month medication. Also, another way to dramatically lower the LDL, the less frequent dosing. And we're even going further to and accelerating pretty rapidly into genetic engineering. Despite some of the ethical and regulatory concerns that we'll have, the science is advancing, and as are the clinical trials. So with this CRISPR editing technology, we're able to go in and precisely turn on and off to precisely identify and literally turn off the PCSK9 gene domain to inactivate it. And this is opposed. Previously we were able to do base editing, which was a little bit more inaccurate. And now we're really pretty accurate, and that's why they're calling it molecular surgery. They did this on primates and are now doing this in phase 1 studies in humans with FH, where they're showing dramatic reductions when they inhibit the PCSK9 protein to levels that are pretty on par with what we're seeing in the clinical trials, about 65%. But this this sustains. We see it, even up to now, and this slide is slightly outdated from the AHA 2 years ago. Now, after 2.5 years, we're seeing that reductions in the 70 to 80% range. And what they've seen is that there's no off-target effects. So they've done screening at candidate sites, and we don't see any off-target effects from doing this genetic screening with the PCSK9 CRISPR gene editing. So before we go further into the science and everything, I was fortunate to be on this publication where we were looking at reasons for non-adherence to statin therapy. And, we have to remember that 50% of people aren't even taking statins, and this is due to a number of reasons, whether it's due to the failure to prescribe statins, failure to intensify statin therapy, or patient factors, education, comorbid conditions, and health system factors. So a lot of reasons feed into this, and so we have to be cognizant of this before we go too far into the deep with some of these medications. So how low can you go with LDL cholesterol? So we know that from the cholesterol treatment trialists that there is a log linear relationship between the concentration of LDL achieved and the reduction in cardiovascular events. With the TNT trial, and then ultimately trials looking at further additional therapies that lower LDL on top of statin therapy, including the IMPROVE trial and the FOURIER trial and Odyssey trial, we are now seeing levels that we haven't seen previously. And that begs the question of, well, are we lowering LDL cholesterol too much and potentially compromising important things that our body needs, such as cholesterol? We know that cholesterol serves a very important purpose in our body. It's to in terms of synthesis of critical hormones, in terms of formation of the myelin sheath in our nervous system. It's a major component of cell membrane. So a lot of obviously critical functions that many of us will be worried about, and many of the patients recognize that, is this a concern if we come in to the clinic with and after using some of these therapies have a very, very low LDL cholesterol. And so the question is this a major concern? And the fact of the matter is, it actually is not too much of a concern at all, because cholesterol, the ones that we see, the cholesterol that's necessary to produce these hormones, these components of cell membranes, et cetera, is predominantly synthesized de novo or within our tissues. Or interestingly, it's actually acquired from HDL. And so as opposed to the common thought that HDL picks up cholesterol from the plaque and brings it to the liver or for excretion, it actually provides the cells with the tissues with a lot of source of cholesterol. The LDL is really a significant source, an insignificant source for cholesterol synthesis. And here's on the right, you see different synthesis for different organs in terms of cholesterol, and you can see that predominantly it's de novo and HDL that provides the majority of the cholesterol that tissues need to produce the steroid hormones that are necessary. However, they didn't just leave that up to chance. So in the 48 RDC trial with Repatha and Praluent, respectively, and here we're showing evolocumab. Here we're showing just evolocumab. Uh, the the FDA required them to measure hormone levels, and so they measured cortisol, they measured ACTH, and what they saw was that between those who were being treated at baseline um, and after treatment, their levels of ACTH and cortisol, obviously very important hormones, were not altered in any way, even 52 weeks out. And that's despite obviously reducing LDL to very low levels. As you saw, the median cholesterol level there was about 25 to 30 in the 48 trial. But what about extremely low levels? So what they saw in the 48 trial, they did a pre-specified secondary analysis or pre-specified sub-analysis of for patients who achieve an LDL of less than 10 milligrams. And then there are a little over 500 patients with a median of 7 milligrams per deciliter. And they saw that log linear relationship with lowering of LDL concentration achieved and cardiovascular events continued, even towards cholesterols in the very ultra low range. Meanwhile, the safety or adverse events was similar between those who achieved an LDL level of less than 10 and those who achieved an LDL level of greater than 100. So we're not seeing those safety effects. And then what about one of the biggest concerns that most patients have, with these medications? Are we potentially compromising critical function of the brain and cholesterol? And is this something that we should be concerned about? Certainly, it raises a concern for someone who doesn't understand the physiology. So that's why this is an important discussion. And what we know is that the PCSK9 inhibitors are not able to cross the blood-brain barrier. So, and that the brain predominantly synthesizes cholesterol de novo or intracellularly. So, meanwhile, HDL itself doesn't actually cross. ApoE crosses, and then HDL is able to it's able to bring over cholesterol that way. However, LDL cholesterol is not able to cross, just like other atherogenic lipoproteins, and nor is the PCSK9 protein. It is too large. So so that concern is really much less of a concern, and the brain supports itself with enough cholesterol on its own. However, again, they remain cautious and comprehensive. And in the Ebbinghaus trial, where they took 2,000 of the 48 patients and subjected them to neurocognitive testing, and these weren't just basic mini mental status exams. These were rigorous scoring of working memory, spatial processing, language fluency, reaction time, psychomotor speed. I mean, pretty comprehensive measures of cognitive function at a higher level. And they looked at those amongst those patients who had LDL levels of less than 25 at baseline and after they were treated, and they saw no changes whatsoever in any of these tests. So we're really not seeing this play out in clinical trials either, as well as in basic science. And this is all the way up to 5 years out. And I don't know if they did further analyses afterwards, but this is up to at least 5 years out. So we can be pretty reassured, at least by the basic science, and at least up to 5 years out, that we're not seeing any neurocognitive effects on a pretty comprehensive level. And as a result, we were part of we decided to write a publish a paper, our guideline, our scientific statement rather, where we went through all the data from all the trials and looked at the impact of aggressive lowering of the LDL cholesterol in the brain. And what we concluded is that the risk is any risk to the brain is not there. We're not seeing that in any of the evidence. And so we should rest assured and advising our patients that for those who are, particularly those who are at high cardiovascular risk in particular, that their risk for dementia from these cholesterol lowering therapies are they're really lowering LDL cholesterol. They're not lowering cholesterol that we need and putting our cognition at risk. That being said, we're talking about pretty aggressive lowering of LDL cholesterol, and it's a major hyper focus on LDL. And so the question is, how much is this pound of prevention essentially when we really aggressively lower the cholesterol? How much is a pound of prevention worth? So this is a nice slide that was published in the Lancet that looked at 27 of the cholesterol treatment trials, and you can see on the x-axis here is the cholesterol in millimoles, increasing cholesterol, and then on the y-axis here is sorry, on the y-axis here is a major vascular events avoided, and on the z-axis here is the vascular risk. So you can see as you go up the z-axis here, the greater the risk, you have the greatest absolute risk reduction. So whereas if you start at a lower risk, such as less than 5%, you have a lower absolute risk reduction, even though the relative risk reduction may be similar to those with a much higher risk. And so this is kind of helpful for maybe fellows and residents who are listening in. It's a nice depiction of the importance of absolute risk reduction and demonstrating that the patient's risk level. The more at risk they are for a cardiovascular event, the more benefit they get. And so really it should, when you're sitting down with a patient and you want to emphasize, or you want to choose this therapy, you want to do it in terms of how much benefit you're going to get, and you're going to get the most benefit for the patient who has the highest level of risk. And another important point to consider is that a lot of these trials were done over 3 to 4 year period, maybe at most, with the exception of the Improve It trial with ezetimibe, which went over 7 years. Most of these trials were really done over a very brief period of time. And this slide is just here to depict that that the more years of treatment, the greater the reduction in major cardiovascular events. So it's really so as you see that there's obviously significant reduction in cholesterol with the Fourier trial, but in some of these other trials, it almost was equal to it and then surpassed it with more years of treatment. So obviously, if the Fourier trial, if they looked at the Fourier trial at this point, it would probably be the most. But the point being is that really we should think about risk being with sustained treatment. So not just an immediate kind of post-MI ACS period. So how are guidelines evolving as a result of some of these insights? So what's interesting is that in the 2022 ACC expert consensus decision pathway on the role of non-statin therapies, they took two groups. They took the ASCVD population and they divided them into two subgroups. So one is, okay, you have the high risk ASCVD patients. So that's those with clinical ASCVD, or actually those without ASCVD and have a baseline LDL greater than 190 or FH, high risk diabetes, high risk primary prevention. Evidence of subclinical atherosclerosis, actually, interestingly, on not just calcium scores, but also chest CT. And then those with very high risk ASCVD. So those are those patients who have one major ASCVD event and multiple high risk ASCVD condition or two major ASCVD events. And major ASCVD events include those with recent ACS, history of MI, history of ischemic stroke, and symptomatic PAD. And that's because a diagnosis of PAD can have a pretty poor prognosis once you get to that point. So in understanding the risk, they developed different targets. So for those who are very high risk ASCVD or ASCVD with so those patients with two or more major ASCVD events or one major and multiple high risk conditions, or they have ASCVD with a clinical diagnosis of FH, you want to use a high intensity statin and then use a lower threshold of 55, whereas previously it was 70, to either add a PCSK9 inhibitor or ezetimibe. And for the patients who have ASCVD, but the high risk ASCVD, but not very high risk, they continue to use that LDL threshold of 70 to initiate an ezetimibe or PCSK9 inhibitor. And with diabetes, again, they did change with diabetes. They said the 10-year risk is greater than 7.5. You would use a high intensity statin, and without diabetes, the 10-year risk greater than 20%, or an inadequate lowering of LDL, you would consider ezetimibe. And this slide is here just to demonstrate that that essentially they're starting to use calcium scores to inform guidelines. So even with the calcium score of 0, if you have obviously if you have FH or premature family history of premature CAD or cigarette smoking, you would still want to recommend statin therapy. And then as the calcium score starts to increase, the level of the target or goal LDL level to achieve, or the threshold to add an additional non-statin therapy, starts to get lower. And with the calcium score greater than 1,000 being the lowest. So they're starting to use a lot more imaging of subclinical atherosclerosis to determine goals of therapy. Another guy, and this just shows kind of the evolution of the guidelines. So from the multi-society guidelines, that's the most recent iteration of the formal guidelines from the AHA, ACC, NLA, and multiple other institutions, where they had the initial 70 milligrams per deciliter for above which you would initiate a non-statin therapy. Since then, we've had multiple iterations of guidelines where we've had lower levels of LDL cholesterol thresholds for the highest risk patients. So in the ESC and EAS for very high risk, and then for patients with greater than 2 events, they even had thresholds of 40 milligrams per deciliter for LDL, all the way down to what we talked about already, the ACC expert decision pathway of less than 55, to the Lipid Association of India, which is a threshold greater than 30, upon which you would initiate non-statin therapy for what they categorize as extreme risk ASCVD. So here you can kind of see really how the risk is driving these goals of therapy. So with this science and these clinical trials and these guidelines, let's circle back to some of these cases that we first came to. So again, for the first case, we discussed that the 59-year-old woman who was a former smoker, hypertension, hyperlipidemia, PAD, so pretty high risk, in the very high risk category, on rosuvastatin and evolocumab, and we went through previously a cholesterol LDL of 3. In addition to recommending lifestyle therapy, based on which of the following lipid lowering recommendations should you suggest? So let's give you guys some time here again to go back to the poll and put in your responses. Okay, let's see the responses here. Great. So we can see that really dramatic improvement here. And just going through, I mean, just going through uh, the responses, obviously you wouldn't want to reduce, or the choices rather, that you wouldn't want to reduce the rosuvastatin to 20 because you want to maintain them on a high intensity statin therapy, although rosuvastatin 20 can be a high intensity. Um, you wouldn't want to switch evolocumab to alirocumab because it's working. You wouldn't want to switch evolocumab to ezetimibe because it's working, and we don't have concerns for low LDL here, and that applies to the choice of D as well. So no further changes would be recommended, and we really should be comfortable with an LDL of three, even though it might seem a little scary to get used to this new science. Okay, so just moving on to the next slide here. Again, to that question, 66-year-old gentleman, hypertension, hyperlipidemia, a coronary status post MI in the last year. So again, coming into the very high risk ASCVD category, currently on rosuvastatin 40, the slightly overweight, slightly elevated blood pressure, but otherwise normal vitals, total cholesterol of 230, HDL of 37, LDL of 69, triglycerides 120, pre-diabetic, slight transaminitis with slightly greater than 2 times the upper limits of normal with a normal creatinine. So based on the recommendations that we discussed from the 2022 ACC-AHA expert consensus decision pathway update, which of the following would you recommend? Would you add bempedoic acid, switch to atorvastatin 80, reduce atorvastatin to 10, given the transaminase, add alirocumab, or no further recommendations? Again, we'll give you guys a minute here. Okay, and let's see the responses. Okay, so again, definitely a significant change from before. So just going through the answers, nobody put add bempedoic acid because it's essentially not going to add much, especially on top of a statin therapy, which is in the same pathway. We wouldn't want to switch to atorvastatin 80. They're already on a high intensity statin. Um, we wouldn't want to reduce the atorvastatin to 10. And I'm glad to see that nobody put that answer because it's kind of a trick choice. But unless the transaminases are greater than 3 times upper limits of normal, we would not change their atorvastatin dose. Um, and but we would, in this patient who is considered to have to be in the very high risk ASCVD category, we would want to go to and add an additional therapy to get them to a very low LDL, and so we would add alirocumab. So that is the right response. So at this point, I'm going to turn it back over to Robert so he can continue with some further cases and discussion.
Ben, that was a fantastic discussion. I would a couple of points I would like to make is when you're dealing with patients with very low LDL, think about ordering an ApoB. I think there's a lot of data that ApoB may be better than LDL, even non-HDL in that situation. There's a recent article in JACC saying that patients who have elevated ApoB have an additional risk above and beyond the LDL goal. So even though they mentioned ApoB in the 2022 consensus guidelines, but in recent data and some personal communication, ApoB lowering even to less than 60 is effective. Now, that patient with a low LDL, you may find that when you ordered a ApoB, it may be not as low as you would think, and you like to see, there's very little risk when ApoB is less than 40. So think about ordering ApoB in a situation like that. And of course, the National Lipid Association, which both Ben and myself are fellows of, now recommend that everyone should have an LPA drawn, particularly in cases like this who are high risk. And even though we don't have therapies for that, therapies are being developed. And I do think that the answer about bempedoic acid could be considered, because because after the 2022 guidelines came out, the clear outcome study came out that bempedoic acid is an effective therapy. And although it's a pathway that runs into it, there may be some additional lipid lowering. So that could be considered possibly. But I'm going to go over a couple of cases.
So, and Robert, thanks. Yeah, I know, definitely. I think those are important points. LPA should always be considered. ApoB is obviously the most accurate measure of atherogenic lipoproteins. And, I think in that particular case, I would say that, bempedoic acid, certainly we could always consider it, but in the setting of already using a statin, the efficacy of bempedoic acid drops significantly because you're already inhibiting another enzyme in that pathway. And you have a more robust choice with the alirocumab.
Yeah.
So, but
I agree. It's a listen. You want to go as low as possible, and you'll get to that better with the PCSK9. So anytime we get that approved, it's hard sometimes to get it approved when the LDL is less than 70. So at least in New Jersey, I'm going to go through a couple of cases. These are patients who they asked me to come up with some cases. These are patients I saw on Monday in my clinic. So this is a 52-year-old woman with a history of rheumatoid arthritis, lupus, previous breast cancer, and marked hypercholesterolemia. Interesting, her LDL was not very elevated after she was treated for breast cancer. Then it zoomed up high in the 400 range, LDLs to 300. She has an 8-year-old daughter who also had very high cholesterol. Now, her diet, she's on a low cholesterol, low fat diet. She had a 0 calcium score, and she did a CCTA, which didn't show significant disease. And I did a genetic test. I thought that she must have some form of familial hypercholesterolemia, and at least doing a GB diagnostic genetic test, there was no abnormalities. So the patient was on 80 of atorvastatin, evolucumab 140, ezetimibe 10, and the cholesterol didn't budge. It was 448, LDL 340, HDL 91, triglycerides 108. Her ApoB was 204, which is very elevated, and the LPA was only 26. So even though genetically I couldn't find that there wasn't evidence that she had homozygous FH, functionally she was acting like a homozygous FH, at least with the response of lack of response to both evolucumab and also atorvastatin. Next slide. Ben, next slide. Okay, so which of the following? I don't have a quiz here. We don't have a quiz for this one. But which of the following would you recommend next? A bempedoic acid, limitamide, which is a microsomal triglyceride transfer protein inhibitor, evinacumab, which is a ANGPTL3 antibody, LDL apheresis, and no further therapy. Ben, what were you doing in this case? Ben, you can unmute yourself for a sec.
Sorry about that. So, yeah, I think this is a great case. Wow, I mean, really high levels of LDL cholesterol. Limidipide has a significant number of toxicity associated with it, and it's still an important therapy and to be able to use, and particularly when we didn't have these other therapies. But if you have evinacumab available, that's always a great first step. And certainly, I think ultimately, if LDL apheresis is available, this patient needs to be hooked into LDL apheresis. I mean, this is a life-changing therapy. It's going to save her life. So I would say LDL apheresis.
Unfortunately, New Jersey, that's not easily available. But we did have evinacumab available. So that's the therapy. Now, you can also argue the patient had a CT angiogram that didn't show anything. Maybe leave this patient alone. But at those levels of cholesterol, I had a hard time doing it. I actually presented this to a few specialists around the country, and they all agreed on even evinacumab or LDL apheresis if available. Lomipidine, I have limited experience in it. And of course, bempedoic acid would not be, it already failed. It's, the receptors aren't working. If atorvastatin and a PCSK9 doesn't work, that wouldn't be effective. And I'm interested, the patient claimed that the ophthalmologist thought that there were some changes there that may be caused by high cholesterol. So that was an interesting comment that the ophthalmologist had. Let's go on to the next slide. Ben, can advance the next slide, please? Okay, so we started on evinacumab, and actually I stopped the atorvastatin and evolocumab, and I just continued Zetia. And this is just 3 weeks later. The optimal effect of this is usually 12 weeks. After 3 weeks, the cholesterol went down to 186, LDL 115, HDL 65, triglyceride 31, ApoB 98, which is remarkable. I mean, here's something where nothing else worked, but this is remarkable how effective this medication. And I found this with a couple other patients similar. Ben, would apheresis have a similar reduction, you think? How much does apheresis decrease LDL?
Yeah, that's a great question. So, I mean, just to touch, I mean, first of all, evinacumab has been really a game changer, particularly for a woman such as herself, who is unable to access, unfortunately, apheresis therapy because of location and geography. Um, and it's obviously this is a significant advance for her. Apheresis therapy would take this further, and you know, for someone who's got um, unopposed LDL for probably quite some time, apheresis would be able to take this cholesterol to very low levels, probably less than 30, you know, depending on how frequently she gets apheresis, which is recommended every 2 weeks. So, you know, obviously we can't tell for sure, and she may need to be on both, but either way, I think apheresis alone could probably, but you know, be sufficient for her case.
Well, she's very happy, and actually, when I mentioned apheresis to her, she's very happy to get evinacumab instead. So I'm very happy with the result. We'll see whether it continues. Next slide. We'll do one more case. This patient also came in the same day on Monday. A 56-year-old woman with history of hyperlipidemia. Her father had multiple MIs in the 50s. She has some mild dyspnea exertion, which she's had for a while. It's a very atypical chest pain. Now, another cardiologist had done a pharmacological stress test, non-exercise, 6 months earlier to clear up her hip surgery. And I read the report, it was negative, and apparently her echo was also negative at that point, with stage 1 diastolic. And she also had very high cholesterol, 305. And interesting, she was on no medications when I saw her, because she wanted to get through the hip surgery first. That's what she told me. Her cholesterol was 305, LDL 202, HDL 74, triglycerides 136, ApoB 143, which is very high, LPA 28. Now, by definition, if her LDL is 202 and her father had MIs in the 50s, regardless of the genetic test, she does have familial hypercholesterolemia, but by definition. But her genetic test was negative. So I thought, let me do, you know, I was going to treat her aggressive regardless, but let me do a calcium score. Well, calcium score was 616 with disease in the LAD, CIRC, and RCA. So next slide. So this is I want to see which ones we would do here. Aspirin 81 milligrams. This could be more than one answer for this one. Atorvastatin 20, rosuvastatin 40, a coronary CT angiogram. We'll go right to cardiac catheterization with coronary angiography. So Ben, which of these would you choose with this patient, given that presentation, knowing that the nucleus 6 months ago was apparently negative, again, non-exercise? You're on mute still, Ben.
Definitely more than one answer here. Great case. I think one, I would start with the rosuvastatin 40 as a starting point. 2, I would definitely put her on aspirin 81, although it's not technically ASCVD. I think that definition, a lot of my colleagues in the NLA, and I don't know if you feel the same way, Robert, but anybody with a calcium score greater than 100, despite what the recent recommendations are, I would put her on that
No,
with the calcium.
I agree.
Yeah.
Yes.
And then the question as to whether to go directly to coronary angiography or not, well, it's a good one. Now, I mean, I think that given the fact that she's symptomatic, we already know she's got a calcium score of 600 or so. You could argue to go directly to coronary angiography. I probably would, given her level of cholesterol and her symptoms. That being said, it's not necessarily wrong to go with coronary CTA. I imagine you'll probably end up with coronary angiography after that, either way.
Well, interesting. Again, I see a lot of patients who have, positive calcium scores, and then we do a stress test and it's negative. And we know from the ischemia trial that, even if you have a calcium score is positive, as long as it's not left mainly asymptomatic, you could get by with medical therapy. Now, her symptoms were relatively vague. It didn't seem like it was definitely ischemia, but I just had a funny feeling about this case, particularly since it wasn't an exercise test. When I do stress testing after a calcium score, I like to make sure everything's negative. There's no acid depression. They could go a good distance. There's no ischemia. So again, another person read the nuclear. I didn't see the EKG, so I wasn't happy with doing nothing, and I chose in this case to do a coronary CT angiogram. Go on to the next slide, and lo and behold, it showed a 25% left main stenosis, which was, and it had an LAD that was calcified approximately greater than 75%, a mild non-calcium 56.9%, a ramus that was severe 70%. And it's interesting, there was a large eccentric non-calcified plaque greater than 90%. Now, what we find sometimes with when we do CTAs, and often the high-grade stenoses aren't always a calcified, so sometimes it's a non-calcified, which is severe. And actually, if you look prognostically, those are much more unstable and much riskier. So again, I told her this information, and after I talked her off the ledge, she's scheduled now for a catheterization, and we'll see. I'm sure she'll need at least one stent, possibly two, hopefully not bypass. But again, these are the kind of cases that Ben and I come up with all the time, and we just hope to make the right decision each time. So I'm sure in this case, catheterization. Again, in hindsight, if her symptoms a little more provocative, I could have gone right to catheterization. Sometimes when you speak to the insurance companies, they give you a hard time over catheterizations in cases like this, and we're not that symptomatic. But I've had a few recently where I'm very happy I convinced the insurance company to agree to catheterization. So that's the end of my slides, and we could go on next. I guess next is the discussion. So let's go on to the next slide, and we can open this up to discussions. Are there any discussions from the audience? Let's see. I don't see anything in question, and it would be in question. I don't see anything in question and answer. I'm sure someone in the audience has an interesting question for us. Well, okay. Well, I guess
If you want, we could. I know we didn't touch on LPA. I think. Oh, it looks like there's a question that hopped up on our.
Oh, good. Let's see the question. Okay. There's one question. Oh, this is from Dr. Feldman. Talk about the calculated LDL when LDL-C is very low. That's a good thing, because Ben, as we know, that calculate. The problem with LDL is it's usually calculated. Sometimes it's a direct, but the calculate method using either of the standard calculations are inaccurate when the triglycerides are high or when LDL is very low. So I think, I'm sure you have the same way. Patients you put on a PCSK9 agent, I get calls my colleagues that the LDL is -10. It's not really -10. I had a poster at the NLA about this, that really when you're looking at low LDLs, you should really be measuring ApoB is a very good thing to measure. But that, again, as you mentioned, a low LDL isn't important, but it may not really be real when you use a calculated value. That's why ApoB is variable. What do you think about that question, Ben?
Yeah, no, it's a great question. I think obviously, like you said, there's a number of different ways to calculate it, from the NIH equation to the standard Fredewald equation, and to the more arguably more accurate the Martin Hopkins equation. But better is the directly measured LDL, and better even from there is ApoB. So I think if you really want to get precise, once you get into that LDL range, or if you have triglycerides or etc., then using an ApoB would be the right way to go.
Yeah, and I think that the real that's a great question. Thank you, for Jeffrey. And when it comes to LPA, I guess you could discuss your experience with. I don't have any apheresis patients, but for LDL and LPA, the elevated LPA is a marker for a high risk, and we are doing a number of trials. I think, are you a PI for any of the trials for LPA? I know Guy was PI for a couple of them. He told me you were doing the Ocean trial, I think.
Yeah, so I'm the site PI for both the Horizons and the Ocean
Ocean.
A trial. And sorry, and yeah, so the Horizon, the Ocean A trial, and
Yeah, I'm
so
also doing the Lilly trial, the Acclaim LPA trial, which is a great trial for if anyone out there has LPA patients in New Jersey. You could contact me. In New York, you can contact Dr. Hirsh. The Lilly trial is interesting because that's not only high risk; it's also high risk primary prevention. I'm also doing a trial looking at aortic stenosis, the progression of aortic stenosis. But I think the key thing is that even if you don't treat LPA, it's a marker for disease, and it's worth checking. The one approved therapy for LPA, though, is apheresis. So maybe Ben could talk about that a little bit. The apheresis.
Sure. So I do have one patient who I have on sorry if you guys hear my daughter in the background. I do have one patient who had actually a bypass surgery, and 6 months later her bypass grafts went down. We checked her LPA; it was 700, and so we actually had her do apheresis for LPA, which significantly lowered her, obviously her LDL, which wasn't terribly high. Actually, her LDL was 34 to start with, but lowered her LPA to extremely low levels. So that's another thing that you consider if you have apheresis available, that these LPA patients, particularly high risk LPA patients, should be considered.
Actually, I'm shocked that patient was approved, because according to the guidelines, you have to have an LDL over 100 and LPA to get it approved. So I'm impressed you got that patient approved with a normal LDL.
Sometimes you have to make a strong case, right?
I know, but that's good to know, because the guidelines, according to the insured, but again, you have to
No,
make a
you're absolutely right. The guidelines do say that, and I think so it's always a case by case basis, and obviously, and a lot of legwork was done, and getting this patient to where she needed to be, for sure.
Well, that's great. We also be advocates for our patients. Anyhow, so I'd like to, if there's no further questions, Oh, there's another question in the thing. Okay. Dr. Feldman mentions also that the Martins Hopkins, if they're high triglycerides, that's what the Martin Hopkins is more accurate than Friedewald than for high triglycerides. Yeah, I mean low triglycerides.
That's a great point.
Yeah, the low LDL. I really would, again, any measuring, LDL below 50. And I think that ApoB is inexpensive and we should be using it more anyhow. So this, again, these patients with low LDLs, they also get ApoBs done. And you'll find that's a very, we're going to learn more and more about that. And the new guidelines may incorporate ApoB when they come out. And we'll see.
And for the masses, let's not forget, non-HDL. So if they
and
yes,
non-HDL cholesterol is just cholesterol minus HDL. It's usually 30 points higher than the LDL goal. But the key thing here is the most important point today is that if you have very high risk, you want to drive the LDL less than 55. And if you look nationally, most cardiologists, most interns and practitioners are very poor at that. Bad at 70, very poor at 55. So really, as institutions, we should be looking at ways of doing it. Again, and just circle back to what we're doing in Atlantic. I presented my study and posted in NLA. We're doing the OLTOP, the Atlantic Lipid-Lowering Treatment Optimization Program, and we're using a nurse practitioner-based program to get everyone looking in our system to get everyone down to an LDL of goal. We're using a nurse practitioner, a team-based approach. And hopefully we'll be presenting that at some future meeting.
That's great.
So anyhow, thank you so much for everyone for being on the call, and don't forget to get your credits for CME and MLC credits.
Thanks very much. Thanks, Robert.
Thank you. Okay.